My name is Dr. Connie Kinchis, and I'm a gynecologist at Alamance Regional Medical Center, and I work at Westside OBGYN Center here in Burlington. Today's Healthy Woman seminar topic is menopause trick or treat, and we've got some interesting information for you, and I hope you'll enjoy. Well, I'm very happy to be with you today to talk about one of the subjects that's near and dear to my heart as a gynecologist, which is menopause. And since I am a gynecologist of a certain age, then the funny thing that happens is that as you get older, your patients get older too. Perimenopause in general is taken to mean that the time from the onset of symptoms that reek of menopause, such as hot flashes and irregular periods and so forth, until that woman's final menstrual period. And the technical definition of somebody who is truly menopausal is that they have gone 12 months without a spontaneous menstrual period. And you'll hear the terms menopause and postmenopausal kind of thrown around pretty much equivalently. One of the questions that patients ask me that I think just indicates how much confusion there is in the mind of many women about this subject is, well, when is menopause over? And the answer is never. Once you are menopausal, you are in that stage of your life for the remainder of your days. Sorry, didn't mean to shock you right off the bat. Okay, so why does this happen? What's going on here? What's the physiology? Well, the bottom line is that menopause is ovarian failure. As women, we are born with ovaries that have a pre-programmed lifespan. If we have menopause, I guess hens can have menopause, but you just run out of eggs, Okay, this is one of these diagrams that everyone hates. I hated it when I was in medical school. Patients look at it and go, what in the world is going on here? But there are a lot of complicated hormone interactions that result from the advent of menopause, or the fact that the ovaries are no longer functioning. Menstrual cycles are regulated in an area of your brain called the hypothalamus. So as women, we're all born with a little menstrual clock in our brain that activates when you're in your early teens usually, and then continues to function for the rest of your life. And the hypothalamus sends signals to your pituitary gland by a hormone called gonadotropin-releasing hormone, and that stimulates your pituitary gland. And then your pituitary gland produces another hormone called FSH, follicle-stimulating hormone, that actually tells your ovaries to produce estrogen. That estrogen that's produced by your ovary does a lot of good things. It causes the growth of the uterine lining tissue. So if you're a young woman and in the reproductive age range and you're still having babies, then that uterine lining tissue that's generated every month creates a place in which a pregnancy can develop. Estrogen is good for your bones. It helps to keep bone metabolism in the direction that we want, where your bones are accumulating or hanging on to calcium. It's involved in your body's temperature regulation mechanism. It causes blood vessels to dilate. It increases collagen production in the skin. And there's a fairly good body of data that suggests that estrogen has functions in cognition and brain function. So it's a busy little hormone. What's the good side of menopause? Well, no periods. What's not to like about that? No risk of pregnancy, so provided that we've all finished our families, and that's an upside too. Cycle-related symptoms like PMS just kind of go away. And there are other issues that may be cycle-related. For some women, migraine headaches are a biggie. They have, tremendous cycle-associated headaches that just kind of go away once the ebb and flow of hormones from the ovaries go away. Symptoms of menopause: you miss your period, you have some hot flashes, or you wake up hot in the middle of the night, or you just wake up for no good reason. You may notice that you have some vaginal dryness, intercourse becomes uncomfortable, or you may notice that your libido is sagging a bit. Let's talk about the hot flashes. Why do we have them? What's the deal here? Well, we mentioned earlier that estrogen is part of your body's temperature regulation system. And when you lose your estrogen, then that poor little hypothalamus in your brain is kind of at a loss for what to do. And it senses overheating. And when your body is overheated, it has a reflex mechanism that dilates the blood vessels in your skin and sends blood flow outward to decrease your body temperature. Now, there are a bunch of symptoms that patients come in to see me about that they're pretty well convinced that it must be menopause, and there's actually very little evidence for that. Moodiness, depression, weight gain. I mean, menopause is kind of the redheaded stepchild of everybody's health, in that you can blame everything in the world on menopause if you are of a mind to. Most of these things don't have a direct connection to it. It's not a hormonal phenomenon. What you can see is you can see mood changes, depression, and so forth as a result of lack of sleep. It's the sleep disturbances that women may have as a result of menopause that create a lot of the downstream effects. So one of the first questions I ask a patient when she comes in and says, I'm just not feeling like myself, I think it's menopause, we immediately start talking about what are her sleep patterns. Because if she's sleeping like a log, then there are probably other things going on. She may have an endogenous depression or just a primary depression rather than something related to menopause. But again, if she's up 3 or 4 times every night, then I want to fix that for her, and then let's talk about her moods and see how they're doing. But the average woman will be significantly symptomatic, enough that you will notice it for about 3 years. Now, that doesn't mean you never have another hot flash after that first 3 years. It just means that the intensity for most women and the frequency for most women will fall off. But again, as I said, some women never have them, and I have patients who well up into their 70s and even their 80s will still be symptomatic. But they're the outliers. But bottom line is, menopause is not an equal opportunity employer. It does not treat women equally. It's a very individual event. I think we've gotten away from the idea that estrogen is the fountain of youth. I mean, there still is no such animal to the best of my knowledge. And it's not a cure-all, but it does have very specific uses, and it is a very useful medication. It's helpful to prevent osteoporosis and bone-related issues. It is absolutely the best treatment for menopausal symptoms, such as vasomotor symptoms like hot flashes or night sweats. And it's also the best treatment for vaginal atrophy symptoms, the vaginal dryness and so forth that women experience sometimes as a part of menopause. Improved sleep, again, if you just shut off the hot flashes and the night sweats, sleep gets better. Vaginal dryness can be an issue. Painful intercourse is not fun for either partner, so relieving those symptoms is a good idea. Women who are at risk for osteoporosis, sometimes who have a family history, will be interested in taking estrogen for that reason. And there are other miscellaneous benefits. I haven't listed them all here, but for reasons we don't understand, the risk of colon cancer is actually decreased in women who take estrogen compared to women who don't. There are some eye-related issues. There's a most common cause of blindness in mature adults is something called age-related macular degeneration. Women who take estrogen have a lower risk of this kind of problem than women who don't. If you'd like to keep your teeth, estrogen is a good idea. Women who take estrogen have a lower risk of tooth loss as time goes on, because it makes sense. I mean, teeth are basically just a specialized form of bone, and we've already said that estrogen in general is good for your bones. So the main downside, which is something that patients still, I don't think, appreciate, is cardiovascular risk of heart attack, risk of stroke. Women all come in to see me and they're all scared about breast cancer, but the real issue is that there's some pretty good evidence that there is an increased risk in particular populations, and we'll get around to that here. So heart attack, stroke, blood clots, these mechanisms are all kind of similar. They all work through the cardiovascular system and the particular effects that estrogen has here. Endometrial cancer can be a risk if estrogen is given inappropriately. In order for women who have a uterus to take estrogen safely, you need to administer second hormones, a progestin or a progesterone-like hormone that counteracts the effect of estrogen to make the uterine lining tissue grow. So that unopposed estrogen means that a woman who has a uterus is given just estrogen and nothing else. That's, with rare exceptions, that's inappropriate. And we don't prescribe estrogen that way unless there are very unusual circumstances. But for women who take, a woman who has a uterus who takes estrogen plus a progestin, she may actually have a lower risk of endometrial cancer than if she were taking nothing. Now, breast cancer, of course, there's a whole bunch of question marks after that because folks have been trying really hard for about the last quarter of a century to figure out what is the connection between estrogen and breast cancer. And it's difficult because there's lots of conflicting data out there. There are a fair number of studies that have shown a modest increase in breast cancer risk among women who take estrogen. There are some studies where the effect is neutral, and there are actually studies out there where women who took estrogen have a lower risk of breast cancer than women who took nothing. Not outweigh the risks, they didn't consider the chief benefit for which I prescribe it. So, should we take estrogen? And the answer is, I think for some women the answer is yes, but how do you do it safely? And as I've mentioned before, almost to the point of preaching at you, I think that women who still have their uterus need to take a progesterone-like hormone along with estrogen to keep the uterine lining tissue from growing. A, you don't want to have a period when you're 60, and B, you don't want abnormal tissue growing inside the uterus. So taking the progesterone along with the estrogen can eliminate both those issues. But if you've had a hysterectomy, you don't have uterine lining tissue, you can take the estrogen all by itself. Estrogen should be taken for whatever the shortest duration of time is that's consistent with keeping that patient comfortable and meeting your therapy goals. And that shortest amount of time might be 6 months, it might be 6 years. You base your treatment on the symptoms. So if the woman is having problems with hot flashes, night sweats, that sort of thing, that is systemic. That means it's affecting her whole body. So she needs to be treated with medication that will circulate throughout her body. If she comes in with basically vaginal symptoms, vaginal dryness, vaginal irritation, pain with intercourse, but not systemic symptoms, then you can treat that locally. You can treat with vaginal medication, which results in much, much, much lower levels of systemic estrogen. There's another hormone we haven't mentioned yet, but it has some effect in the world of menopause as well, and that's androgens. Androgen is a general term that means male hormone, okay? Even though we are women, our ovaries produce mostly estrogen and just a pinch of androgen. And that pinch of androgen that our ovaries produce actually is the hormonal basis for libido in women and in men both. Now, of course, men have more than a pinch of androgen, but for women, that little bit of androgen produced by your ovary is the hormonal basis of libido. Now, in women, libido is a lot of things. It's your lifestyle, it's how well you're getting along with your partner, it's how stressed you are at work this week. There are a variety of things that affect libido in women, but the hormonal basis is androgens. And in some women, when your ovaries stop producing estrogen and androgen, some women will notice a fairly obvious decrease in libido. I find myself increasingly, not exclusively, but increasingly prescribing generic estrogen, oral estrogen, and generic progestins. But there are these other things out there. They're the rings, the mists, whatever, and they're not bad products. And for some women, they might be absolutely the best thing, but you will pay for them. And oh my gosh, there is all sorts of stuff out there that people want to sell you nowadays. I mean, you get on the internet. There are menopause supplements. I mean, I can't even drive to work in the morning without hearing advertisements for menopause relief products. And again, if you look at these bottles, read the fine print, somewhere down there it's going to say that these statements have not been evaluated by the FDA for either safety or efficacy. So again, we all have to take care of our problems in the way that we see fit, but do be careful and be skeptical about these things, because there are folks out there making a whole lot of money off of selling sometimes what amounts to snake oil to menopausal women. There are a handful of websites I can direct you to that will give you fair, balanced, up-to-date information regarding menopause-related issues. Up to Date is a super website. It's actually a professional website that's run by and for physicians and health professionals, but they have lay content there that is very well done. So if you go to that particular website, then you can look up a variety of menopause topics and get some pretty good information. There's actually a whole professional society devoted to menopause, the North American Menopause Society. So as you can imagine, they've got some pretty good information there too. American College of OBGYN, and the American Society of Reproductive Medicine. Womenshealth.gov is, again, this is actually from the CDC, the Department of Health and Human Services. They've got great content there. So it's just a matter of getting to their homepage and looking for the little prompts about menopause, and you can spend some pretty profitable time looking at kind of what the latest data is and what our latest understanding is regarding hormones and menopause and what works and what doesn't.
Okay, I've been waiting for this seminar and I have been requesting it, and I learned a lot and I think it was great, and all the things that I learned, I do plan on trying to help my life with this problem that I have, so I think it was great.
I learned a lot from the doctor's seminar today. It was just great, and I'm sure this is going to help me in my daily life. It gives me the information that I need to work with, and I'm just going to work with it. And if need be, I am going to see her soon because she's wonderful.